Okay, we're going to go ahead and get started. So thank you everybody for joining us. I'm accepting this invitation to come celebrate Hispanic Heritage Month with us at the John P. Hussman Institute for Human Genomics. I'm not sure if everybody knows, but we are located at the University of Miami, and we form part of the Miller School of Medicine. So I'm just going to give a quick intro into who we are, and then we'll discuss a little bit more about Hispanic Heritage Month and the future of Hispanics and aging. So the University of Miami Miller School of Medicine is actually ranked #2 in the nation for human genetics research funding from the National Institutes of Health. We have over 23 faculty members and over 120 staff members. You can see some of our team members here attending a recent conference, the Alzheimer's Association International Conference. And we actually have 4 distinct centers that cover genome technology, genetic epidemiology and statistical genetics, education and outreach, and then molecular genetics. Here you can see some of our core faculty and study leadership. So the director and principal investigator of our Alzheimer's disease and related studies is pictured here. It's Dr. Margaret Paracak Vance. And then her husband, Dr. Jeff Vance, is also a faculty member here. He's a professor of neurology, and he helps us a lot with our classification systems. Dr. Newton-Yeamans is also a faculty member here, and she heads the related dementias or other dementias research studies. We also have 2 more individuals who help us on these studies and are part of the leadership. Dr. Gary Beecham, who handles studies for early onset Alzheimer's disease, and then Dr. Kugro, who specializes in psychology and behavioral sciences and helps us with understanding the evaluations that we do in Hispanic and other minority populations. We are located, as I said before, on the University of Miami Medical Campus at 1501 Northwest 10th Avenue. So if you're interested, please stop by. Here is a list of our presenters today. I'll be starting off. I'm a clinical research coordinator for the Hispanic Alzheimer's disease studies. Then we'll be joined by my colleague, Dr. Martinez, who is the lead coordinator for the related dementias research studies. And then finally, we'll be receiving a presentation from Melissa, who is a research coordinator for the African American studies. Okay. So we're going to start off by explaining a little bit about what Hispanic or Latino Heritage Month actually is, and then transition a little bit into the aging and dementia in Afro and Hispanic communities. So Hispanic Heritage Month actually begins every single year on September 15th, and it runs for a full month until October 15th. It was started in 1968 by Congress as just a week, but it was eventually expanded to a full month in 1988. The reason it starts in the middle of a month as opposed to at the beginning, like Black History Month, is that actually a string of countries celebrate their Independence Days on the 15th, 16th, 20th, on the 18th and 21st. So this is why it begins in the middle of the month. So even though it was established almost in 1970, which is about 50 years ago, believe it or not, we've also noticed other trends in the Hispanic community, which is that we've been exponentially growing. In 1970, there were only about 10 million Hispanics in the United States. However, this number has increased all the way to over 62 million in the last census that was conducted in 2020. Another trend that we've also seen is the amount of Hispanics who are self-identifying as multiracial. So in 2010, only about 3 million Hispanics identified with having heritage from more than one race. However, this number has increased to 20.3 million in the most recent census. So Latinos and Hispanics are incredibly diverse, and we want to make sure that we represent all of the cultures and ancestries that make up the Hispanic and Latino populations. One of the most important contributors of the Hispanic culture is, of course, our Afro-Latino roots. So in 2010, the Afro-Latino population was 1.2 million, compared with approximately 389,000 in 1980. So we can see that this number has basically tripled over the last 3 decades. Currently, about quarter or 24% of US Hispanics self-identify as Afro-Latino. And there are also very large percentages of Hispanics that identify as mixed race, as we previously discussed, as solely Indigenous or as Afro-Latino. It's important for us here at the Hussman Institute that we study all populations, especially diverse populations, because they provide a unique opportunity to discover novel targets and pathways and ensure that all groups benefit from research. So we're not only interested in understanding a disease in one specific group of people, we want to make sure that the treatments, diagnoses, or whatever information that comes out can really be applied to all groups. Here we can see the number of Afro-descendants throughout Latin America represented in the thousands. So obviously countries like Venezuela, Brazil, Dominican Republic, which are traditionally thought of as having large numbers of Afro-Latino descendants. We can actually see here there are Afro-descendants in all of the countries throughout Latin America, and that they make up that they contribute to a large portion of our population. So another unique factor about Hispanics and Latinos is that we are an admixed population. So admixture is when two or more groups come together and produce offspring that are a genetic combination of these populations. So here in this chart, we can see that there are 4 examples of 4 individuals who are 100% Han Chinese, 100% French, 100% Suri representing the Americas, and 100% Yoruba representing Africa. If these individuals were to have children together, these offspring would be a combination of their parents. Here we can see some of the percentages for the communities that we study here at the Hussman Institute, such as African Americans, Cuban Americans, Dominicans, Mexican Americans, Peruvians, and Puerto Ricans. As we can see, they are all a mixture. And this is just the average, an approximation of what the average participant from one of these groups would look like. So it's always great when we have a greater number of diversity in our participants, and to get as many people to participate as possible so that we can see what these differences are in terms of how much inheritance we have from each continent, and also what this inheritance means in terms of our risk for different diseases such as dementias. Here we can see the distribution of ancestry of self-reported Latinos across the United States. So in this particular study, about 9,000 self-identified Latinos who participated in the company 23andMe were mapped out across the United States. So here we can see the average amount of ancestry in a customer from 23andMe who's from Illinois, and has self-identified as Latino, and we can see these represented across the different states of the United States. As we can see, the greatest contributions are Native ancestry, African ancestry, and European ancestry, and that these also tend to differ depending on where you are in the United States. And this just highlights how multidimensional and multifaceted the Latino population is in the United States. This also gives us a little bit of information about the migration of different ethnic groups into the United States or across the United States, and of course, the admixture of these 3 cultures. So US Hispanics, they tend to defy the odds, actually. We outlive non-Hispanic whites by 3 years on average, despite having lower income and education levels. In 2014, life expectancy at birth for the US Hispanic population was 81.8 years compared to 78.8 years for the non-Hispanic whites in the United States. So a little bit of happy news there for us. However, there are many factors that often prevent Latino elders from enjoying their golden years. Chronic health conditions such as cardiovascular disease and diabetes disproportionately affect Hispanic, Latino, and Black populations. And then, of course, we have to deal with lower levels of and quality of education, higher rates of poverty, and greater exposure to adversity and discrimination. These all end up contributing to the risk for dementia, and it also contributes to the risk for developing a chronic condition, such as the ones that we previously discussed. We take a look specifically at South Florida with the example of Miami-Dade County and Broward County. We can see that there is a large percentage of the population that self-identifies as Hispanic, Latino, or Black or African American. However, we also have to take note of the fact that a very large percentage of the population is actually over 65 years old. So when we talk about the Hispanic community, especially locally, we have to consider the issues and the future of the aging community or those who are over 65. There are about 166 adult daycare centers in operation in Miami-Dade County. However, there's only about 26 in Broward County, even though population estimates are comparably similar. Hispanics and Latino peoples are about 1.5 times more likely than non-Hispanic whites to develop Alzheimer's disease or other dementias. And then Black Americans are about twice as likely to develop Alzheimer's disease or other dementias. It is also expected that by 2030, 40% of all Alzheimer's disease patients within the United States will identify as Latino and or Black. So dementia, Alzheimer's disease is definitely going to be a prevalent issue in the Hispanic community. I want to take a little bit of time to inform everybody here more about dementia and the different types that we study here at the Hussman Institute. So first thing that we have to clarify is that when we say dementia, it is an umbrella term. So it describes multiple conditions, and it's a general term for the loss of cognitive functioning, the ability to think, remember, reason, to such an extent that it interferes with a person's daily life and activities. So some of the common skills affected are memory, language, visual, perception, problem solving, self-management, and the ability to focus and pay attention. Under the general umbrella term of dementia, we have specific types of dementia that have been categorized. The most prevalent, most common type, which accounts for about 60 to 80% of dementia cases, is Alzheimer's disease. And that is one of the principal projects that we have here at the Hussman Institute. Besides Alzheimer's disease, we also study Lewy body dementia and frontotemporal dementia, along with some of the contributing factors that vascular dementia can have in our community. Later on, we're going to discuss these two types, Lewy body dementia and frontotemporal dementia. But for now, I'm going to give a brief overview of what Alzheimer's disease is. So Alzheimer's disease, or AD, is a progressive disease. This means that dementia symptoms gradually worsen over several years. Symptoms begin to occur because nerve cells involved in thinking, learning, and memory have been damaged or destroyed. So the most important effect, the most common effect is this decrease in cognitive function, which often first starts off as memory issues. So eventually the parts of the brain that enable a person to carry out basic bodily functions, such as walking and swallowing, are also affected. On average, a person diagnosed with Alzheimer's disease lives 4 to 8 years after diagnosis, but they can live as long as 20 years depending on other factors. Here are some of the warning signs of Alzheimer's disease. Of course, the most common one that's usually listed is memory loss, which usually starts off as forgetting recently learned information. So when people begin to have memory problems, the majority of their memory problems are not going to be around things that they learned in their youth. It's going to be about these new bits of information that they are going to have increasing difficulty retaining. So some of the other signs are going to be difficulty performing familiar tasks, such as cooking a familiar recipe, disorientation, which begins as getting lost in a familiar place, language problems, such as forgetting simple words, names of objects, loss of initiative, abstract thinking problems, such as problems with simple math, or perhaps making change or checking out at a store, misplacing things. So we see that a lot of people begin to lose common objects when they're beginning to display signs of Alzheimer's disease, mood and behavior changes, personality changes, and then poor judgment can also be signs of Alzheimer's disease. So as we see here, Alzheimer's disease is a progression. This means that it gets increasingly severe over time. However, it does begin in this stage where there are no symptoms present. We have seen through research that there are changes, and of course there are genetic factors that are present way before people even begin to experience symptoms. Once these small symptoms do begin to present, somebody may be classified as having a mild cognitive impairment, which is when these very mild symptoms do not interfere with their everyday activities. Individuals are usually able to maintain a level of independence. However, we see that these symptoms begin to interfere more and more with the daily activities as time goes on. Eventually, we see that symptoms interfere with most everyday activities, and patients do need to be under 24/7 care. So let's talk about some of the risk factors for developing Alzheimer's disease. The greatest risk factor, and usually the most common one discussed, is always just increasing age. The older that you become, the greater your risk of developing Alzheimer's disease. Family history also has a huge component in risk. Research has shown that people with a first-degree relative, so that means mother, father, a child possibly, but usually you'll begin to present symptoms before your children, that you're 2 to 3 times more likely to develop it. This is due to, of course, the genetic factors within our DNA, and that is the focus of what we study here at the Hussman Institute for Human Genomics. Race and ethnicity also play a role, as there tends to be a higher rate of Alzheimer's disease in Black Americans and Hispanics and Latinos. Women are also more commonly affected than men. And then health conditions such as heart disease, diabetes, stroke, high blood pressure, high cholesterol, head injury, or depression can all increase the risk of developing Alzheimer's disease. So as we previously said, the greatest known risk factor for Alzheimer's disease and other dementias is increasing age. However, we have to note that these disorders and that memory problems are not a normal part of aging. While age increases risk, it does not directly cause Alzheimer's disease. After the age of 65, risk doubles every 5 years. And then by age 85, the risk reaches nearly 1/3. Let's talk about the genetic risk factors, which is the majority of the research that we do here at the Hussman Institute. So scientists know that multiple genes are involved in Alzheimer's disease. But first, let's take a step back and discuss what exactly are genes. So each human cell contains the instructions that that cell needs to do its job. These instructions are made up of DNA that is tightly packed into structures that are called chromosomes, which we can see here in the image. Each chromosome has thousands of segments called genes, a gene being the basic physical and functional unit of heredity, or the inheritance of characteristics between families. These instructions are passed on within families. So the participation of families and individuals in genetic research is crucial to identifying these incorrect instructions that can increase risk for Alzheimer's disease or other dementias. What we do know about the risk factors, genetic risk factors for Alzheimer's disease, is that there are 2 types of genes that can increase your risk. So risk genes increase the likelihood of developing a disease, but do not guarantee that it will happen. The prime example of this is ApoE4, which remains the Alzheimer's gene with the strongest impact on risk. People who inherit 1 copy of this type of gene have an increased chance of developing Alzheimer's disease. However, they're not guaranteed to develop it. Those who inherit 2 copies, so 1 from their mother and 1 from their father, are at an even greater risk. Additionally, those who have this gene may tend to have symptoms appear at a younger age than usual. There are also deterministic genes, and these are the type of genes that directly cause the disease. So those are guaranteed to develop a disorder if they have this in their genetic makeup. These genes are estimated to account for 1% or less of Alzheimer's disease cases, and they usually cause early onset forms of the disease, which means that symptoms present earlier in life, usually in a person's 40s to mid-50s. Currently, the state of Alzheimer's disease genetics research is rapidly expanding. Congress has actually approved funds through bipartisan support because we know that not only in the Hispanic community, but throughout the whole United States, as individuals are aging and the amount of the population that's over 65, and we see that dementias and other neurodegenerative diseases are going to be a large issue in the elderly community. So the large scale sequencing project, which is trying to sequence different Alzheimer's disease genes is currently underway, and we're hoping to recruit over 70,000 individuals. But we want to make sure that this group is ethnically and racially diverse so that all groups benefit from these new discoveries. The Hussman Institute is actually leading the way. So here you can see some of our headlines that were recently in the news. You can go to our website if you want to read more. But basically, one of the most important things that we want to do is make sure that there are large numbers of people participating in genetic research. Because if you can't see it, if you don't have somebody with that particular gene, you're really just never going to be able to find out information about that. And we also want to make sure that as many people participate as possible, but that these are representative groups that represent everybody that lives in the United States, and especially minority groups. Here we can see the really international and national collaboration trying to understand the genetic causes of Alzheimer's disease. So when you participate in a study with us, you can rest assured knowing that we're not just going to keep these results here at the University of Miami. We're not just going to keep them private to ourselves. We really are about connecting with everybody possible to try to expand the knowledge on dementias and Alzheimer's disease to benefit as many groups as possible. Currently within the United States, there's about 6 million Americans living with Alzheimer's disease. It's also the sixth leading cause of death in the United States, and 1 in 3 seniors dies with AD or another type of dementia. Within the state of Florida, there's over 500,000 individuals living with Alzheimer's disease over the age of 65. And then this number is expected to increase to over 700,000 by the year 2025. So next, my colleague, Dr. Martinez, is going to give you guys a little overview on the other types of dementias apart from Alzheimer's disease.
Okay, thank you, Mary Carmen, for that introduction. Please confirm that you can see my screen.
Yep, we can all see it.
Okay, thank you. So I will be discussing other dementias associated with aging and neurodegeneration. And my goal here is to try to help you identify and understand some of the main characteristics. First, we are going to begin talking about frontotemporal dementia, and also known as FTD. And this disorder is characterized by a group of disorders that occurs when nerve cells in the frontal and temporal lobes of the brain degenerate. You can locate your frontal lobes in the area behind your forehead, and the temporal lobes in the areas behind your ears. This degeneration can lead to loss of nerve cells that can affect behavior, personality, language, and movement skills. Only rough estimates are available, but there may be 50,000 to 60,000 people living with FTD in the United States, and the majority of those with FTD are between ages 45 to 65. Over 30 to 40% of patients have positive family history, so this suggests that there is a important genetic component. So here, I wanted to discuss the different types of FTD. First, we have the most common type, which is the behavioral variant. This one will present with changes in social behavior, judgment, and personality. Also, the patient will be repeating behaviors or routines. They will have changes in eating habits. For example, they will either eat a lot or not eat at all, and poor decision making. Another type of FTD will be the language variant. This one will affect the speech, and the patient will present with difficulty speaking, loss of meaning of words, difficulty in recalling words, and difficulty understanding single words. Another common type of related dementias is Lewy body dementia. This one refers to either of two related diagnoses. The first one will be dementia with Lewy bodies, and the second one, Parkinson's disease dementia. They both are caused by abnormal deposits that damage brain cells over time, and this damage affects the person's ability to think, reason, and process information. An estimate of 1.4 million Americans are living with Lewy body dementia, and here we included a picture of Robin Williams, who was originally diagnosed with Parkinson's disease. However, an autopsy after his death showed that he had dementia with Lewy bodies. So here we wanted to illustrate three main distinctive features of Lewy body dementia. The first one, unpredictable changes in alertness, attention, concentration, and wakefulness throughout the day and week. The second one, and this one occurs in up to 80% of the cases, is very common, are the visual hallucinations. And the third one, the Parkinson-like movement symptoms such as the rigidity, the lack of spontaneous movement, the tremors. So even though they share some of the movement symptoms and they can be very similar to each other, Lewy body dementia is not the same as Parkinson's disease. And the big difference is in the time frame for when the cognitive symptoms begin after the movement symptoms. For example, in dementia with Lewy bodies, the cognitive symptoms are seen within a year of the movement symptoms, versus in Parkinson's disease dementia, the cognitive symptoms develop more than a year after movement symptoms begin. So regarding the genetic risk factors for FTD and Lewy body dementia, we have that FTD and Lewy body are a lot less common than AD, but together they make up about 10 to 20% of all dementia cases. So these small numbers make studying their genetics very difficult. But overall, more research is needed to identify more genes, and specifically in our population of other than non-Hispanics whites, which are traditionally being underrepresented. So here we have a chart of core dementia symptoms of the most common symptoms of dementia according to the age of onset. We are comparing Alzheimer's disease, frontotemporal dementia, and Lewy body dementia. And as you can see, the age of onset here is different on each type of dementia. And for Alzheimer's disease specifically, the memory loss is the most prominent symptom at age of onset, and then following by frontotemporal dementia, which the most prominent symptom here will be the behavioral changes or the language changes. And then Lewy body dementia, we have, will present with memory loss, hallucination or delusions, and movement symptoms as well. So. Okay, another very common type of dementia that we wanted to mention because of its contributions to Alzheimer's disease and other type of dementias is the vascular dementia. This one is considered the second most common cause of dementia after Alzheimer's disease. And it is caused by conditions that block or reduce blood flow to various regions of the brain. And these blockages deprive the brain of oxygen and nutrients and can lead to a decline in thinking skills. These thinking difficulties may begin as mild changes that gradually worsen as a result of multiple minor strokes or other conditions that affect smaller blood vessels, leading to a widespread damage. Some of the risk factors and also most of the most common medical conditions in our populations of Hispanics and African Americans are the hypertension, diabetes, elevated total cholesterol levels, low physical activity, lower high body mass index, coronary artery disease, among others. Then we have mixed dementias. This is the least common type of dementias, and it's a condition in which brain changes of more than one cause of dementias occur simultaneously, meaning at the same time. Autopsy studies play a key role helping us understand mixed dementias but scientists cannot yet measure most of the dementia-related brain changes in a living person. So we listed the diagnostic measures for dementia that are currently available. And first, we wanted to mention the medical history and physical exam. This one will lead the physician to make a clinical diagnosis according to the symptoms of the patient and any medications that they are taking at that time. Also, the neuroimaging is very important. They can provide different images of different parts of the brain and lead us to a cause to try to make a clinical diagnosis of the dementia according to the part of the brain that is affected. And then we have the cognitive and neuropsychological tests. This one include assessments in memory, in language skills, math skills, problem solving. And this one are also used here at the HIG for our current studies. And finally, we have the biomarkers and genetic tests. This can also help us to try to determine a type of dementia, especially the genetic test for patients that have a family history of dementia. However, autopsy remains the only way to officially confirm the diagnosis of dementia as of right now. So since there are no current treatments to stop or slow dementia, and the medications that we use right now are only to treat the symptoms, such as the behavioral changes, the delusions, depression, etc. However, we believe that there is hope. And with the help of the genomic research and the information that we can obtain on these genetic variants, we can help in the diagnosis, the prognosis, and the development of new treatments. Also, drugs targets with human genetic evidence of disease association as twice as likely to lead to approved drugs. Though many genes are being identified for AD and other dementias, much information is still missing, so especially for our communities that are other than non-Hispanic whites. And it is our goal here at the HIG to fill in this gap. Okay, so now we are going to continue with my colleague, Melissa.
Thank you for that introduction, Anisli, and welcome everyone to our celebration and acknowledgement of Latino Heritage Month. We've so far talked about the toll that it takes on the person who is affected with dementia or Alzheimer's disease. But right now, through the information presented in my portion of the talk, we're going to expand on the experience of the caregiver of someone with Alzheimer's disease, or any other dementia. This can also expand into the caregiver's role in someone of another dementia type. I first want to begin by laying the groundwork for defining what caregiving is. Someone who becomes the caregiver for someone with dementia or Alzheimer's disease more specifically is responsible for a whole host of things. And in this slide, I've outlined a few of some of the main responsibilities of someone who is the caregiver for someone with dementia. This can include attending to this person's day-to-day health needs, as well as their overall well-being, providing emotional support to the people who, these people who are experiencing or diagnosed with Alzheimer's disease, being able to communicate and coordinate the care of this person with other family members and their healthcare providers, ensuring their safety at home and elsewhere as this disease becomes more progressive and interferes more with this person's independence, as well as being able to manage the health conditions that this person may have in addition to their diagnosis with dementia. And now we're going, the caregiving in itself is a all-encompassing around-the-clock task that has a lot of costs that are both financial and lifestyle. In a few facts collected from the Alzheimer's Association, we kind of get a perspective into just how all-consuming as well as involved as caregiving can be. In 2020, 11.2 million people reported themselves as caregivers of people with Alzheimer's or another dementia, and they provided an estimated 15.3 billion hours of informal assistance. And if that assistance was more formal, it would be valued at $256.7 billion. The total lifetime cost on average to care for someone with dementia is on $373.5 thousand, accounting for inflation back in 2020. We're not accounting for inflation, but in 2020 dollars. And someone who is caregiving for their spouse and also happens to be experiencing any mental or emotional strain at that period has an increased risk of dying at 63% higher than someone who is the spouse of someone they're not giving care for. And to kind of help us conceptualize everything that both Mary Carmen and my colleague Anise Lee mentioned earlier about the stages of dementia, I wanted to help personalize it and introduce a scenario in which we walk along a situation that might happen in an elderly couple. So I'd like us to meet Martha and Fernando. They have been married for over 30 years, and throughout these 30 years, Martha has kept her wedding ring in a jewelry box on her dresser, the same place for 30 years. But recently, she's been diagnosed with a dementia. In the early or more mild stages of dementia, if Martha was looking for this wedding ring, knowing that she has stored this in the same place for a while, because of the mild dementia, she may forget where she keeps this wedding ring in this jewelry box. But after some time, we'll remember. If this same situation occurs during the more middle or moderate stage of her dementia, she may forget where this wedding ring is while looking for it or where she usually stores it. And after a few minutes or moments of looking, may not remember looking for this wedding ring in the first place. And if the same situation were to happen in her more late or severe stages of dementia, she may completely forget what the wedding ring symbolizes, much less keep an effort to look for this wedding ring because it's important to her. And now I want to pivot into who the people who become caregivers in our communities. They come from many different walks of life, fill up many lifestyle habits and occupancies. And I just want to put into perspective just how wide and vast that group of people who make up caregivers can be. So the people that I'll outline here were collected from a survey conducted by the Alzheimer's Association, where they were asked to identify caregivers of people with Alzheimer's or dementia and the people who made up that group. And in this group of people surveyed, 30% of them were adults over 65. More than 2/3 of these people who were identified as caregivers were women. 10% of the people who were surveyed here were identified as Black or Hispanic. These people were married or in long-term relationships. They're taking care of a parent and a child at the same time. They happen to be taking care of their parent or a parent-in-law. And some of them even fall into the millennial category, where they're young and middle-aged adults who are caregiving for an elderly loved one. And now that we know that there are so many different vast identities that can become caregivers, why do these people assume the, again, all-encompassing around-the-clock task that can become caring for someone with Alzheimer's disease or dementia? Some of these caregivers who were interviewed cite love, a sense of duty, as well as a sense of obligation when they described what motivates them to become caregivers and assume all of those caregiving responsibilities for a relative or a family friend or close friend living with dementia. They also cite mistrust, a fear of neglect and abuse of a loved one, as some of their primary motivators to take all of the care upon themselves. More intimate testimonials describe this person's desire to keep a family friend or family member at home or as close to their own independence as possible. And this person's, or the caregiver's rather, proximity in relationship to the person with dementia is a primary motivator in keeping up with their care as a primary caregiver. And I wanted to harp on why these reasons were so significant, because a lot of these reasons echo why many people who make up the Hispanic and Afro-Latino community assume the care of their elderly loved ones, because family is family, as well as paying forward all of the care and sacrifice that these people or their loved ones gave to them in their upbringing. Kind of an act of paying it forward also is cited among people that we're in contact with within the community, who cite why they become caregivers. So we've also discussed more of the financial concrete cost of caregiving, but there are more lifestyle costs that come as a consequence of being someone's full-time caregiver, which include burnout from the constant caretaking tasks. Some people endorse developing depression or anxiety from the stress that's related to caregiving. And while we've mentioned the financial strain of the unpaid labor, there is more concrete financial costs that are either unexpected or out of pocket on behalf of the caregiver or on the caregiver's part that come with the task of caring for someone with dementia. But we do also want to make sure that we highlight that there are some joys that come with caring for a loved one who's experiencing stages of dementia that are invaluable. And that includes more quality time with this elder, getting in touch more intimately with your own family history through interactions with this loved one, the experience of affirming your support networks that you have within your community and family. Because of how deeply involved caregiving can be, you really have an opportunity for your community members and your extended family to show up for you and your loved one. It also helps whoever the caregiver is to be more closely aligned with their own values through the very intimate task that is caregiving. So thus far, I've discussed some of the tolls, the costs, what it's like to become a caregiver, but we really want to be able to stress the fact that a caregiver is only as effective as how well as they've been able to take care of themselves. So it's essential for whoever decides to assume the care of someone with dementia to prioritize self-care in their day-to-day life so that they can show up as the best version of themselves for this loved one. And for anyone who plays a caregiver role, who is among our viewers, I want you all to think about how, if you have been incorporating self-care in your weeks, how you can continue that, and if you haven't, how you can incorporate more of that into your day-to-day as a caregiver for someone with dementia or Alzheimer's disease. And we have some suggestions. So some different ways to self-care that don't involve so much intention can be something as simple as taking some time to take a walk, scheduling a spa day. And if the resources don't allow for a spa day, you can do something as small as setting apart some time to soak your feet in Epsom salt, or enjoy your favorite show, even with your elder or your loved one. Making sure that you take some time to prioritize your rest, as well as prioritizing mindfulness, because caregiving for someone with dementia can bring about a slew of complex emotions that, as a caregiver, you may not have time to parse through as you're consumed with the around-the-clock care of a loved one. So taking time throughout your day or throughout your week to be mindful via writing in a journal or taking some time to eat outside will do wonders for your ability to maintain your own wellness while you can take care of yourself. And I want us to think about the analogy of in an airplane where if there's a crisis in the airplane or it's going down and your oxygen mask drops, the flight attendant and anyone who is telling you about your safety on a plane tells you to put your oxygen mask first before you help the person next to you, whether it's your child, your parent, or any loved one. I'd like us to consider that same analogy when we talk about caregiving for someone with dementia. You can only, again, take care of this person that you love so much as best as you can take care of yourself. So we encourage everyone here who is in connection with either people who are become caregivers or are caregivers themselves to really consider ways to prioritize self-care for themselves. Self-care also looks like being in touch with resources in the community, and that can be anything from support groups for people who are also caregiving at the same time, as well as grief and bereavement groups to anticipate the grief that comes with watching a loved one go through this complex disease. Setting some time, some concrete time to yourself to run errands, something as small as finding a resource like an adult daycare facility in your area will do wonders for how you're able to manage all of the competing tasks that come with caregiving. The Alzheimer's Association also does a great job at being able to connect people who are experiencing Alzheimer's disease, either via a loved one or themselves, with resources and information in their local communities. You can access a link or directory through the Alzheimer's Association website that outlines events that are happening in your area regarding Alzheimer's disease and caregiving, as well as multiple directories for resources like daytime transportation, as well as adult daycare directories as well. It's an invaluable resource for people who are looking to share resources with caregivers, as well as compile resources themselves as caregivers. And lastly, I want to harp on the fact that caregiving for someone with dementia is a job that takes a village. And it's a team effort, the same way that we at the Hussman Institute, in developing tools to treat and eventually cure dementia, are working through research as a team effort. And our team here is not complete without you. Helping us by participating in research ensures that our communities are included in new medicines, tests, and treatments. Personalized medicine is the future of healthcare, and here at the Hussman Institute, we're working with our local communities to have an active role in bridging that disparities gap. And at the Hussman Institute, the scope of our work ranges from everything between community education, so informative talks like this with community partners, our research behind the scenes and in the labs through our work with discovering Alzheimer's disease genes mentioned earlier, as well as raising awareness for all of the aspects and different dimensions that come with caregiving. And we do this using a two-pronged approach where our primary mission is to discover how genes influence a variety of human health and diseases, but we want to do this using cohorts that actually represent the population spread or the population distribution in our area, especially as it relates to Alzheimer's disease, as older Black and Hispanic Americans are disproportionately more likely to have AD, but are grossly underrepresented in research. So it's essential for us here at the Hussman Institute to work to identify these genetic factors that define disease risk across groups. And Alzheimer's disease risk specifically can occur at different rates or in different instances across different ancestries. So being able to really understand what that combination of ancestries looks like and how it plays a role in one's risk for Alzheimer's or dementias of the future is really all we strive to do here. And eventually, we would like to develop, we would like our research to have a hand in developing personalized medicines or personalized treatments, genetic testing or more fine-tuned genetic testing for diagnosis, better and improved treatments, and possibly prevention of a lot of diseases that have genetic origins. So just a perspective to what it looks like to participate in some of the studies that we have here at the Hussman Institute. Through your participation, we keep all of the information confidential. No travel is needed. We meet whoever is interested in participating wherever they're most comfortable or where they feel is best. Their participation is completely voluntary and consent is ongoing throughout our research process. There is no cost to participate, and some may even qualify for compensation. And most importantly, our visits are conducted with our participants in their preferred language. With that, that brings the end of my talk. Thank you so much for your attention.